بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. In the last few lectures we talked about the stage 1 of implant procedure. This stage is implant placement stage. We talk about flap design for this stage. We talk about some basic factors in implant surgery. Today, inshallah, in our lecture, we will talk about grafting procedure for implant placement. Grafting procedure is very important in the implant procedure. It can be done before implant placement or it can be done during implant placement. Inshallah, in this lecture, we will talk in some details about the grafting material types and clinical application. Now, what are the purposes of using grafting techniques in implant surgery? One, to enhance implant placement. Sometimes the bone dimensions are not enough to receive our implant. In this case, we should rebuild this bone using graft material to increase the bone dimension to be able to receive our implant. Two, to enhance aesthetics and improve soft tissue. When we have bone resorption, that means the soft tissue will follow this bone resorption and the result will be gingival recession. If we plan to insert implant or there is no implant in our treatment plan, it's very important to graft the resorbed bone. That because always soft tissue follow the bone, and this procedure, the grafting of the bone, will enhance the aesthetic and improve this soft tissue. Three, to change the pre-existing jaw relationship. When we have class 2 relationship, that means usually we have resorption in the mandible. In this case, we can make grafting in the mandible to make this class 2 relationship to class 1 relationship. If we have class 3 relationship, that means we have bone resorption in the maxilla. In this case, we can use grafting material to increase the bone dimensions in the maxilla and make the class 3 relationship to class 1 relationship. Bone graft usually can be used as particles or powder or sheets or large blocks. Classification of bone graft materials according to their action. We have three main types of bone graft. First type is osteogenesis bone graft. This graft contains bone forming cells, which is osteoblast, in the graft material. We mean that this bone graft material can start bone formation from its material. Second type is osteoconductive bone graft. It serves as a scaffold for bone formation from the surrounding bone. We mean this graft can act as scaffold or bridge or matrix for bone formation from the surrounding bone. This is filler material. This material will fill the space of the defect, of the bony defect, and the bone formation will start from the surrounding bone to the bone defect. Third type of bone graft is osteoinductive bone graft. This material is filler material, but inside this material there is growth factors which can stimulate the bone formation. Stimulate the bone formation. The most important growth factor is the bone morphogenetic proteins, BMPs. We mean osteoinductive bone graft has the ability to promote de novo or new bone formation removed from the host bone even within non-calcified tissue. As I told you, bone morphogenetic proteins, BMPs, and other growth factors have this property and are used to increase the effort to optimize the effect of bone augmentation material. Classification of bone graft material according to their sources. We have four main types of bone graft according to their sources. First type is the autogenous graft. We mean by autogenous graft that grafts transferred from one position to another within the same individual. This bone graft is harvested from your body to your body. If you have defect in the bone of your maxilla, we can take bone graft from the mandible to augment this defect in the maxilla, or we can take a graft from your bone in the hand or in the rib or in the iliac, etc., to treat this bone defect. This type of graft is harvested either from intraoral location or from extraoral location. The most important extraoral donor sites is the hip marrow graft and the iliac crest marrow. For the intraoral donor sites, we will talk about them in the next slides. What are the autogenous graft advantages? First, availability. Your body is available for your body. Always the factors your body is the factors of this graft. That means it's always available for your bony defect. 2, sterile. Usually we make the harvesting of the bone graft and the grafting procedure in the same time and in the same operation room and under the same sterile circumstances in the operation room. 3, biocompatibility. Of course, your body will not refuse your bone. That means it's biocompatible. We have our graft is biocompatible with your body completely. 4, this graft is osteogenesis bone graft because it's a fresh bone and there is osteoblast inside the bone graft material. And this bone graft is osteoconductive because its filler material will fill the bone defect and will act as a scaffold for bone formation. And it's osteoinductive graft because there is a lot of graft of growth factors and BMBs inside this bone graft, and this bone graft will start the stimulation and will make the bone formation more fast. That means autogenous graft is 3-in-1: osteogenesis, osteoinductive, and osteoconductive bone graft. The fifth advantage of the autogenous graft, that is, it's easy to use. Usually, not always, using of autogenous graft is easy, especially from the extraoral position. In the intraoral position, maybe it will be easy, but extraoral sometimes it's not easy, it's difficult. What about the disadvantages of the autogenous bone graft? One, limited volumes available, particularly intraorally. When we have a huge bone defect, that means we need a big quantity or a huge quantity of bone graft, which is difficult to be available intraorally, and in this case we need an extraoral location donor site. Two, access to good donor site, because we need two axes in this surgery: one axis for harvesting of the bone graft and another axis for the treatment of the bony defect. Three, post-operative pain and other operative sequelae. Usually using autogenous graft is combined with more pain, more swelling, more bleeding than the other type of bone graft. For potential damage to adjacent structures, maybe during the harvesting the bone graft we make injury to a nerve or to a blood vessels or to another root during the harvesting of the bone graft, and this will make a disadvantage of the autogenous bone graft. The second type of bone graft, according to their sources, is allogenic graft. Allogenic grafts are grafts transferred between genetically dissimilar members of the same species. When we use bone graft from Muhammad to treat a bony defect of Ali, that means this bone graft is allogenic grafts from human to human, or from cow to cow, or from horse to horse. This is allogenic graft. We will talk about the human graft only. We will not talk about grafting between animals. In the allogenic grafts, we mean always the human bone graft. The graft, we have two main types of allogenic graft. First type is FDBA. What mean FDBA? Freeze-dried bone allograft. Freeze-dried bone allograft. That means they are bringing the human bones. They will freeze this human bone. After that, they will dry this bone and sterile it and package this bone graft. This is the first type of allogenic graft, FDBA. The second type is DFDBA. which means decalcified, freezed, dried bone allograft. They will bring the bone, the human bone, they will freeze it, they will dry it. After that, they will remove the minerals from this bone graft and they will sterile it and they will package this bone graft. DFDBA mean decalcified, freeze, dried bone allograft. Both of these grafts usually are containing good sources of bone morphogenetic proteins, BMPs, but in DFDBA, the quantity of the BMPs is huge that make DFDBA osteoconductive and osteoinductive. DFDBA osteoconductive and because it's filler material and osteoinductive because it contains a lot of BMPs which will stimulate bone formation, while FDBA has limited quantity of BMPs which make it only osteoconductive, we mean as a filler material. This picture shows different types of allogenic graft. The allogenic graft can be used as a body, or as bone blocks or a bone powder or particles. The third type of bone graft, according to their sources, is the xenogenic graft. Xenogenic grafts are grafts taken from a donor of another species. Usually we talk about graft taken from an animal to treat the bony defect of our patients. The most important and the most famous brand of bone graft is BioOs. BioOs is a bovine-sourced deproteinized bone graft. That means this bone graft harvested from cows after removal of the proteins of this bone. That means this bone graft is minerals alone without proteins. This graft, because this graft is purely mineral graft, it will be osteoconductive graft. Osteoconductive graft, that means it act as a scaffold, it's filler material, and thought it will undergo some resorption and this resorption will be slow. This picture shows boxes of BioOs bone graft. Here it's powder bone graft in the picture, but there is in the market another type of BioOs in the shape of bone blocks. Fourth type of bone graft, according to their sources, is alloplastic graft material. This material is synthetic or inorganic implant material which are used as substitute for bone graft. They act as a framework or a scaffold for bone formation on their surface and are therefore osteoconductive filler material. The most important or the most famous types of this bone graft are hydroxyapatite, calcium phosphate, tricalcium phosphate TCP, or bioactive glasses. Let me now give you a fast summary about the bone graft types according to their sources. First, autogenous graft, that means graft harvested from a donor in the same individual, from you to you. This bone graft, as I told you, is osteogenesis because it's a fresh bone graft, contain osteoblast, and osteoconductive because its filler material act as a scaffold for bone formation, and osteoinductive because it has a huge quantity of growth factors and it will stimulate bone formation. Second type is allogenic bone graft. This graft harvested from a donor from another members of the same species, يعني between a human to a human. This is a human bone graft. We talk that there is two main types of this bone graft: FDBA, which is osteoconductive filler material or scaffold, and DFDBA, which is osteoconductive and osteoinductive, two in one, because it's filler material and it has a lot of growth factors which will start stimulation of bone formation. Third type is xenogenic graft, that means bone graft harvested from another species, from animal to human. That material is osteoconductive because it's usually mineral bone graft and it acts as a scaffold and filler material. Fourth type is alloplastic material, a synthetic or inorganic material, which is osteoconductive also because it will act as scaffold or matrix to or filler material for bone formation. Guided bone regeneration, GBR. What is the principle of GBR? If we have a bony defect and we use bone graft to fill this bony defect, after that we make the closure of the wound and the suture. What we expect will happen inside the bone graft material? We will expect the bone graft will resorb and it will change into a bone to fill the bony defect. But in fact, this can't be always. Why? Because the epithelial cells are very fast in formation and it will grow inside the bone material. It will prevent from complete bone formation inside the bony defect, and the result will be osteofibroformation. That means the defect will be filled by bone mixed with fibrous. This is not what we need from the graft and what we need from the grafting procedure. What we will do in this case, we can cover the bone graft by a membrane. This membrane has a porous surface. Porous surface means a surface with very small holes. These small holes allow only the osseous cells to penetrate from the surrounding bone to the bone material and will prevent the big epithelial cells from penetration the membrane to the bone defect. This will allow bone formation inside the bone defect. Guided bone regeneration, or GBR, mean prevention soft tissue formation inside the bony defect while in the time or in the duration of bone formation. The membrane also has another advantage, is to fix the bone graft and prevent the bone graft from movement during the healing time. The main aim of GBR procedures is to cover the bone graft and prevent soft tissue formation inside the bony defect and to fix the bone graft in place and prevent it from movement during the healing and the formation of the bone inside the bony defect. In the picture, you can see a bony defect. Now it's filled with bone graft. After that, we cover it by the membrane. After that, we make the suture. The other picture shows the surface of the membrane, which is porous surface, allows only for bone cells to penetrate to the bony defect and prevent the epithelial or soft tissue cells from penetration the membrane to the bony defect and making osteofibro formation inside the bony defect in the aim of having complete bone filling of the bony defect. Classification of membranes. First type of membrane is non-resorbable membrane. This membrane requires removal at second stage surgery. Example, polytetrafluethylene, PTFE membranes, and titanium membrane. That means this membranes need another surgical procedure for removal of this membranes after the complete bone filling inside the bony defect. The second type of membranes is resorbable membrane. This membranes will resorb after it act as a barrier or as a preventer of the soft tissue formation inside the bony defect. It will resorb after bone formation. For example of this resorbable membranes, synthetic polymers such as polylactic or polyglycolic acid membranes and collagen membranes. In the pictures you can see the non-resorbable membrane. First picture shows the polytetrafluoroethylene membrane. The brand is cytoplast membrane. Cover the bone graft. We can fix the membrane using small tacks to make more stabilization of the bone graft during the healing period. The other picture shows the titanium membrane and the clinical application of the titanium membrane after bone formation. In this picture, you can see the resorbable membrane, it's collagen membrane, covering the bone graft. There is a suture over the membrane and the graft to prevent any movement of the graft and the membrane during the healing period. After time of the bone formation, this membrane will resorb. The body will resorb this membrane, and no need to remove this membrane in another surgical procedure. Here you can see the bone graft and the membrane cover the bone graft, and the membrane fixed by small tacks or screws to prevent the movement of the bone graft and the membrane during the healing period. Another picture of clinical application of membrane. There is bone graft under this membrane. This membrane is stabilized by using small tacks for prevention of the movement of the bone graft and membrane during the healing period. Now we will talk about intraoral harvesting and the grafting of the autogenous graft. Autogenous bone graft usually are used as block grafts or as granules or chips. First picture shows osseous coagulum, which mean bone granules mixed with chips of bone mixed with the blood. Second picture shows bone block fixed by small screw to be stable in a place. Autogenous bone block graft. First location of harvesting bone graft from intraoral position is the bone graft harvested from the interforaminal region of the mandible. We mean the chin. Usually fairly large graft may be taken from the interforaminal region of the mandible under local anesthesia. After we prepare our mucopreosteal flap and we expose the bone via a circular incision to give wide exposure of the mandible. The graft can be outlined leaving at least 8 mm of clear bone below the apex of the incisor teeth to protect the nerve and the blood supply to them. Now, that means the limit of our graft must be apical than the apex of the incisor, the mandibular incisors, by 8 mm at least to protect the nerve and the blood supply to these incisors. We should be careful during the cutting of the bone graft. We can cut the cortical bone in the buccal side of the chin. Our cutting must be limited in the cortical bone in the first. After we penetrate the cortical bone, we should stop from complete cutting to reach the cortical bone of the lingual wall of the mandible, because if we reach the lingual part of the bone, it can cause a perforation and lead to hemorrhage from the lingual soft tissue, which can be difficult to arrest. After we penetrate the cortical bone of the buccal wall of the chin, we can use and reach the cancellous bone. We can use the chisels to harvest the bone, leaving the cortical bone of the lingual wall of the mandible intact without any cut. Here you can see the flap for harvesting of the chin bone graft. Large exposure of the chin bone in the buccal area of the mandible. We can imagine the location of the apex of the mandibular incisors. After that, we can start outlining the cutting apical than the apex of this incisors by 8 millimeter. This is another picture, shows the outline of the cutting of the bone graft from the chin. You see this cutting is far enough from the apex of the mandibular incisors. The cutting limitation inside the cortical bone of the buccal part of the chin. We can use for this cutting disc or micro saws or diamond burrs or piezo instrument, which is ultrasonic instrument, to make cutting inside the bone. After we cut the cortical bone and reach the cancellous bone, we can use our hand chisels to remove this part of bone graft from its place. After that, we can cover this flap by sutures. The second site for harvesting autogenous bone block from the intraoral locations is bone block harvested from the mandibular retromolar area. Retromolar area is the area which is located distal to the last molar in the mandible. In the picture you can see the bone harvested from the retromolar area of the mandible. In this picture, the way of harvesting of the bone graft is through fine drills. is trophine drills. The retromolar area can provide good sized graft of high density bone because it's taken from the mandible, which is high dense bone. In this picture, you can see the trophine donor site from the lower retromolar area. The trophine drill is a cylindrical hollowed drill can be inserted inside the bone. It looks like حفارة الكوسة مقوار الكوسة the same action of حفارة الكوسة. It insert inside the bone, take the bone block from the retromolar area or from another side of the mandible or maxilla. The third site of harvesting the autogenous bone blocks graft from intraoral location is block graft harvested from the maxillary tuberosity. In the same way of taking the bone graft from the retromolar area, we can take the bone graft using trophine or another instrument from the maxillary tuberosity. This graft may also be used for harvesting bone block graft, but the bone density in the maxillary tuberosity usually is poor because it comes from the maxilla, which is usually most of this bone is cancellous bone, not dense bone. The fourth intraoral site for autogenous bone block graft is block graft harvested from the ramus and the external oblique ridge. Large blocks may be taken from the ascending ramus and external oblique ridge coronoid process as well as the buccal aspect of the body of the mandible. We can use rotary burrs, surgical burrs, or piezo instrumentation, or micro saw or discs for harvesting this bone graft from the ramus area. This site is preferred over the chin by most of the maxillofacial surgeons. In the picture, you can see the outlining of the bone graft using this. In this picture, we used the surgical burrs for outlining of our cutting. After we penetrate the cortical bone and reach the cancellous bone, we can use the hand chisels to remove this bone block from its place and use this bone block to harvest another bony defect. As we talked before, the bone graft, the autogenous bone graft can be in two shapes: bone blocks or particles or granules. For the particle or granules, we can use the bony coagulum, which is granules of bone mixed with chips of bone. To harvest the bony coagulum, we can use the bone trap. Bone trap is a device connected to the suction during the cutting of the drilling of the implant or the cutting of the bone, this device which is connected to the section, will suck the blood mixed with the particles of the bone. There is a filter inside this device will collect all the granules of the bone inside this filter. We can, after finishing the section, we can take this device out and take the bone graft, the bone granules and the chips from the filter and use it to treat our bony defect. In this picture, you can see the bone cutting from the bone trap, the granules and the chips after we remove the bone trap from the section, and we collect good quantity of bone graft to use it in the treatment of our bone defects. There is another device to collect the bone coagulum, the bony coagulum as an autogenous bone graft. This device is safe scraper. Safe scraper is an instrument, looks like potato scraper. We will use this safe scraper to scratch the bone from the donor side. After we make our scrubbing or scratching of the bone, we will collect this bone granules from the device and use it for grafting our bone defect. Once the material has been harvested, it can be shaped to fill the defect with irrigated burrs or hand instruments such as rangers or chisels. Ideally, the graft should be adapted to give a close fit to the recipient bed. With any small residual deficiencies made good with bone chips and osseous coagulum. The bone graft, the bone block, must be adapted, must be cutted to be adapted or to have good adaptation to the recipient bed. The recipient bed should be perforated with round surgical burrs to promote bleeding from the underlying cancellous bone, to encourage vascularization and union of the bone graft. After we make good adaptation between the shape of the graft and the shape of the donor site, and we make the perforation or decortication of the recipient bed, we will fix our graft using screws in place, and we will fill any deficiencies between the block and the recipient bed by we will fill this deficiencies by bony coagulum, by granules or by powder to complete filling the bony defect. Here in the first picture you can see the bone defect. The second picture after flap reflection, you see we made perforation in the bone to encourage the bleeding from the cancellous bone and increase the vascularization of the bone graft, which we want to put it on the bony defect. You can see the recipient bed. The bone defect is perforated using surgical burrs. The bone graft now, we put the bone graft on the bone defect, and you can see the membrane which is prepared to cover this bone defect. Another case, you see the recipient bed with some perforation for encouraging the bleeding from the cancellous bone, with the bone block is screwed in place using small screw to be stable in place. The other picture shows that we start putting bone graft as granules around the bone block to fill all the deficiencies around this bone graft and to fill the bone defect completely. The success of the graft procedure is dependent on the following. First, the stability of the graft and associated blood clot. We should fix the bone graft in place without any movement during the healing period, the bone formation period. We can use titanium screws or using titanium membrane or using titanium mesh or barrier membrane to cover the graft. After that, we can fix the membrane by using small screws or tacks. Second factor for success of the graft is good closure of the wound at the grafted site. It must be complete with great emphasis on achieving a hermetic seal with a little tension or no tension of the soft tissue flap as possible. In the first picture, you can see the bone blocks fixed by screws to be stable during the healing period. The second picture shows the titanium mesh covered the bone graft, and the titanium mesh is stable by fixation screw to prevent any movement during the period of the healing. Thank you very much for your attendance this lecture. I wish you have the complete benefit from this lecture. If you have any question, please contact me and I will answer all of your questions. Thank you again and goodbye and good luck.